Okay, guys, so I'm starting now. So good afternoon, everyone. So today is very special day because it's the last day of our series. And also, I thought of making this the most interesting lecture and a very special day regarding also the scientific content. We've been doing this course, can you believe it, since April 20th. So over, 40 days now. We've been enjoying this company and we've been enjoying listening to many lectures. We have went over maybe 30 lectures so far, and we enjoyed all of them, and they're all excellent. We can't really tell which one was better than the other. Without further ado, I'd like to start my lecture today. I'm very excited about this lecture. Sorry for the spelling error here. With a great colleague. He is a leader. He is a true leader in pathology and in medicine. Dr. Neil Theise from NYU School of Medicine. He is professor of pathology. He is member and fellow and leader of many societies. He is editor of major reference books in liver diseases. Dr. Theise is a physician scientist and the professor of pathology at NYU in New York. His academic efforts are diverse. He is considered a global thought leader in human liver disease. His clinical pathologic correlation studies having reshaped approaches to diagnosis of liver pathologies and revealed the stepwise progression of human hepatocarcinogenesis. In regard to the hepatocarcinogenesis with radiology colleagues at NYU, he pioneered the use of detailed liver explant radiologic pathologic correlation, which have been key to the development of current radiologic systems of diagnosis that includes LIRADS and OBTN. Recently, he co-developed the first clinically relevant staging systems for assessment of fibrotic progression versus regression, the Beijing classification in chronic viral hepatitis. His human liver stem cell work led to the basic science effort which helped to establish the field of adult stem cell plasticity around the turn of the millennium. He has written chapters and edited major reference books in liver diseases, including Maxwell Pathology of Liver, Robbins Pathologic Basis of Diseases, and the 10,010 WHO Blue Book of Classifications of Tumors of Digestive Systems. Well, if I want to talk about Dr. Theise, I'm probably going to take the whole weekend in uh, introducing him and talking about what he did. All of what I want to say that I'm really appreciative that he agreed to give us from his precious time and present together with our friend Claude Sirlin. I'm not going to talk about Claude so much, but Claude knows how much I like him and how much I really appreciate what he did to the science. And what he did, he is the founder of LIRADS. That's enough introduction for Claude. So LIRADS that has been implemented now in the majority of the world and has been helping people with liver diseases and has been helping radiologists in categorizing the observations they see in chronic liver disease, has helped the whole world in coming up to a consensus and helping radiologists in making the sound diagnosis of chronic liver disease. And I'd like to, sorry for my lengthy introduction today, but I just felt to give a word before finishing our series today. And hopefully we'll be in touch. So we'll speak further after the lecture. So I hope you guys stay with us after the lecture. And I'm giving Dr. Theise the presentation now. So Dr. Theise.
Thank you, Khaled. When you asked me to give you a bio, I didn't think you were actually going to read it. Thank you. And I'm really deeply appreciative of your opening thoughts. Thank you for bringing our attention to perhaps the most important issues of the day. Not to say that what we're going to talk about now isn't important, particularly if you're someone who has chronic liver disease and are worried about developing cancer or worried about having to diagnose it. I'd have to start by saying that I don't think anybody has ever read any of my papers as carefully as, can you see my screen?
I don't. Am I actually choosing the right Neil, or is there another Neil that I need?
Try the other one. Yeah, that one.
So I'm choosing that one. Which one I'm choosing now? Choosing the incorrect one? Okay, great. That's perfect, actually.
Okay.
Okay.
For years, I've gotten calls from Claude, who reads a dysplastic nodule paper of mine and asks me, like, what I really meant by a specific sentence. Fortunately, I was never actually forced to go back on something I wrote because it turned out I miswrote it. But since I started getting those phone calls, I've been really thrilled how he has taken the pathology work that my colleagues and I have produced and made them useful for you guys, and thereby useful for clinical hepatology in general and oncology. So that would be my opening statement. Claude?
Well, thank you, Neil. My opening statement is similar to yours, but from my perspective. And my perspective is that maybe 8 years ago or so ago, I had an opportunity to write a review article on radiology of liver cancer and its correlation with pathology. So I started reviewing some of the literature, and lo and behold, I came across all of these articles from Neil Theise. This guy named Neil Theise, his article started showing up in the literature maybe in the early 1990s. And some of his articles were some of the most thought-provoking and original articles I had seen. And so I don't remember exactly how it came about, but I emailed him and I told him that I had read some of his articles and I had a few questions. And would he, and I guess he is you, of course, Neil, would you mind if I asked you some questions? And you said, sure. And so I knew you were a busy guy, and so I thought maybe we would talk on the phone for 5 minutes, and then you'd tell me that you didn't have time for me anymore. But instead, we talked on the phone for about 2 hours, and then that led to another phone call that lasted about 2 hours, and then that led to you giving a lecture to the LIRAD steering committee on some basic concepts of hepatocarcinogenesis. So I'm eternally grateful to you, Neil, not just for your intellectual creativity, but also for your intellectual generosity and your willingness to talk with me for so long. I'm not going to give your email address away to everybody, but if I did, I know that you're willing to have 2-hour phone calls with everyone who contacts you. So Neil, thank you.
Sure. No, thank you. So here's what we're going to do. First, we're going to, well, let's see if I can make this work. Okay, I have to use, okay. So these are our disclosures. Notice, this is what the life of a senior radiologist is like, and this is what the life of a senior pathologist is like. Never mind. A lot of the stuff we're going to show you, specific cases, and a lot of the current context for my collaboration with radiologists is with these two guys who are primary liver folks here at NYU. And we're deeply indebted to Krishna and Miles for how they pulled together cases to go along with some of our pathology images, really at last minute, full steam ahead notice. So thank you, guys. And out of this, we're thinking the four of us should actually collaborate on some extended teaching, and we're trying to figure out ways to facilitate that and where to do it and how to do it. So stay tuned for those announcements. We're going to talk, this is sort of the map of what we're going to be doing today. I'm going to give you the pathologic definitions of dysplastic nodules, and then Claude is going to sort of insert himself in, showing radiology correlates or terminology similarities between what we're doing pathologically and you doing radiology. Then we'll go into what are the associations with hepatocellular carcinoma, because this wasn't always clear that this was a that these were related. And then what the studies we've done from a pathology standpoint in human tissues say about how hepatic carcinogenesis happens. Then we're going to go into how that led to the international consensus of 2009. We'll do case presentations and then open it up somehow. I think, Claude, you'll know how to do that for Q&A. So we'll start with definitions and pathologic features of dysplastic nodules. It's really sort of simple. Dysplastic nodules are defined as, and this is a phrase, I might have actually written this phrase, I'm not sure, in several papers, are distinctive nodules that differ from the surrounding parenchyma in terms of size, color, texture, or their degree of bulging from the cut surface. So notice that this is all based on a gross appearance. It's not based on a microscopic appearance. And here are some examples. Oops. Oh, there we go. Okay. We might have animation problems. I'm not sure. So here we've got an explanted liver for hepatitis C cirrhosis. And here we have a nodule. It's about 1 centimeter across in greatest dimension. And so it differs from the other nodules in terms of that size. It stands out because of its size. Here's a distinctive nodule in a patient with chronic alcoholic liver disease. We see a different pattern of scarring than we see in the hepatitis C. And this nodule stands out not only in terms of its size, it's much larger than the others. So this is a classic Lennox cirrhosis with a micronodular cirrhosis, but it's also very dark. And we'll see why it's dark in a little bit. And here we've got hepatitis B cirrhotic liver. And again, here's a nodule that stands out from the others in terms of its size, but also its texture. It bulges a little bit more, its color is a little different. So it's simply a distinctive nodule. We don't know what it is, we just know that it's distinct from all the other cirrhotic nodules. And when you look at this under the microscope, it doesn't have a true capsule. And this is something Claude has pressed me on quite often, the nature of the fibrosis around the liver. And so we're going to have a little digression here. These are 2 dysplastic nodules in a cirrhotic liver, another cirrhotic liver, trichrome stain staining collagen blue. And you see that the quality of the collagen between the cirrhotic nodules is no different than the quality of the collagen around the dysplastic nodule itself. And that's because it is no different. I'll show you what a true capsule looks like in a few images, but this is what the pseudo capsule that you guys talk about looks like. It's simply the type of scarring you see in chronic liver disease. There's a lot of stuff in this slide, and I just want you to be aware. Oh, I meant to put the reference in it. I'm sorry. So this actually is a version of this that I put in Robbins, but you should look at, if you search for Ian Wanless, W-A-N-L-E-S-S, I'm sorry I didn't put his name on the slide, and Regression of Fibrosis, this all sprang from his brain. And basically, this is how pathologists understand how chronic liver disease leads to an advanced stage liver. You start off with, here's a schematic of portal tracts, terminal hepatic venules going into central veins, and then you have some sort of liver disease that leads to parenchymal extinction events. So you get thrombosis of small vessels. And notice it's 2 hits. There's enough collateral flow between all sections of the liver that if you lose a portal vein, it's not really going to make that much of a difference. But if you lose a portal vein and you lose the outflow in that area, then you've got no flow. And the hepatocytes atrophy away, you activate stellate cells, inflammatory cells move in, there's collapse of the reticular meshwork, and so you wind up with extinction of hepatic parenchyma in a zone. And as that collapses, and as the stellate cells activate, scar tissue is deposited in these areas, and scar contracts, so structures start to adhere together in ways they normally wouldn't. And then because of distortions in blood flow, some hepatocytes are going to further regenerate. And as they do, you're going to get compression of scar and expansion of fibrotic nodules. What we now know is that there is a second thing that can happen, because now we can cure diseases, or we can get diseases to remit. So an alcoholic can stop drinking, hepatitis B can be suppressed long-term, we can cure hepatitis C, and if that happens, then you can wind up with scar regression, degradation of scar, revascularization of the parenchyma, and hepatocyte regeneration. And in some patients, they can actually go back to a normal functioning liver. So this process is what I want you to think about as we move forward, describing what's going on around the connective tissue around a cirrhotic nodule, and return to this again, the notion of parenchymal extinction leading to scar. And this is just trichrome stains, collagen blue, an active drinker, 6 to 12 months of abstinence prior to transplant, and then 4 years of abstinence. How we got this liver, that's a long story for another time maybe. But you see the areas of parenchymal extinction that are inflamed, edematous, there's lymphatics, there's capillaries in here, there's stem cells regenerating in here, and there's stellate cell activation. When you stop drinking, you start to get regression of the scar, and these nodules start merging together. But the key thing for you guys at this moment is this is what parenchymal extinction leading to fibrous septum formation in the liver looks like. Now, back to dysplastic nodules. Another feature of them is that they always contain portal tracts. So on my screen, I have a little go-to meeting box over here. Is this obstructing anyone else's view, or do I just see it? Claude, do you see something there?
I see your, all I'm seeing is your slides right now. Is there something else you're showing?
Okay, so never mind that. That's because I've got control. So if you zoom in an area of this dysplastic nodule, you see that there are portal tracts and there are central veins distributed, sometimes even in an almost completely normal distribution. And this becomes important later on for what we think, how we think these things grow. The key thing here is, grossly, I couldn't tell whether that was this was a dysplastic nodule or an early small cancer. It can't really be cancer, though, if it contains portal tracts, because cancer pushes the portal tracts out of the way. And so if it contains portal tracts, it makes it far less likely to be cancer. Not 100%, and we'll get to that by the end of the lecture as well. But so a key feature is dysplastic nodules contain portal tracts. In the absence of any portal tracts anywhere in here, I'd have to wonder about a well-differentiated HCC.
Okay, so Neil, thank you so much. So for the audience, whenever you see this little path LIRADS correlation in the upper left-hand corner of the slide, that's sort of our clue that I will be then showing some sort of conceptual correlation to what Neil just discussed. And I'll get to that in just a second. But before I do, I just want to ask a few questions of Neil. But Neil, maybe we should answer them at the end or offline. But my questions are the following. Can you, on a gross explant specimen, reliably differentiate alcoholic cirrhosis from viral cirrhosis? You implied that you might be able to because you saw that, you said the pattern of fibrosis looks quite different. So that's something that we might be able to discuss at the end if time permits. Another thing that you mentioned is the Ian-Wanless hypothesis or model for parenchymal extinction, beginning with thrombosis of the inflow and the outflow, inflow via the portal vein and outflow via the hepatic vein. The question I have for you, though, is that in early viral fibrosis and in NASH, for example, and I believe in alcohol as well, we get fibrosis either periportal, you know, in the setting of, say, viral hepatitis, or lobular, I think, in the setting of NASH and in the setting of alcohol. And I'm not sure that that early fibrosis occurs after the portal vein and the hepatic vein are thrombosed. I thought that they sometimes develop even while the portal vein and the hepatic vein are widely patent, and maybe I misunderstood some of what the concepts are.
It's complicated, and you have to go disease by disease to some extent. But the short answer, the other question, yeah, that could be for later or offline. But this question, I didn't say that fibrosis depends on thrombosis leading to parenchymal extinction. I said fibroseptum formation. So we normally think, you know, the way we're taught to think is that portal fibrosis extends out bit by bit by bit until it links up with other portal tracts and then becomes scarred. Alcohol, we do see that actually happening. The scarring happens perisinusoidally and extends outward, 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 and then eventually hits the portal tract. But overall, when you actually look at fibroseptum formation and cirrhosis, and this is what Ian did, you find these thrombosed vessels all over the place. What gets rid of the hepatocytes? It's not the creeping fibrosis, it's the fact that they atrophy. And you know, the support for this, it's a large volume of literature that I would highly encourage people to go take a look at. In particular, Wanless's first paper on regression, which followed up on these ideas. It was rejected from a number of high-level liver journals and was finally published in, I think it was the American Journal of Clinical Pathology. Not a bad journal, but not very high level for something like this. And it was rejected by all 4 reviewers, but the editor felt that Wanless was too authoritative to just out of hand dismiss it. So they published the paper. Each of the reviewers wrote a commentary on the paper, why they thought it wasn't true, and then he wrote a response to that, and it was all published in the same volume. It's a really monumental little bit of liver history. So it's a very complicated question, but the short answer, which I'm really hard at ever giving, is that what I was referring to is replacement of parenchyma by fibrosepta. I wasn't talking about every little bit of scar that develops in the early stages of disease.
Okay,
But
Neil, yeah.
that early stage fibrosis also interferes with vascular supply to the regions where it's involved. So it's a dynamic interplay.
Got it. And by the way, for the audience, I hope you can appreciate that this is kind of the dynamic between Neil and me. I ask a very ignorant question, and Neil, instead of just blowing me off, he actually gives me, you know, a very erudite and clear response. So Neil, thank you.
2 hours.
But we're not going to spend 2 hours on this one topic for everyone. We'll do that later. But the interesting thing here is that after discussions with Neil about his concept of a distinctive nodule, that's how we in LIRADS came up with the idea of the observation as being an area that is distinctive from the surrounding parenchyma in terms of size or intrinsic imaging features or contrast enhancement. So Neil, this concept that we have of observation comes from your concept of the distinctive nodule. Now, the reason we call it an observation and not necessarily a distinctive nodule is that we're not always sure that what we're looking at is actually a nodule. So in this particular case that you see in front of you, this is obviously a nodule. But there are times when we see things and we don't know if they're nodules or perfusion alterations or something else. So anyway, Neil, thank you for giving us the concept of distinctive area.
Sure. Thank you for using it. Thank you for listening to me. I'm not sure anyone ever does. And now you all are familiar with the idea that we talk about low-grade versus high-grade dysplastic nodules. That again was, these were concepts that were years in development, starting with when people started identifying these lesions in Japan, and those distinctions were first made. And then outside of Japan, there were a number of us. And then there were consensus meetings between all of us. So none of this like just happened. This was, I'd say, a decade-long process. So we now understand low-grade dysplastic nodules. You can see my cursor, yeah?
Yes.
Okay. Low-grade dysplastic nodules have normal cytology of hepatocytes or large cell change. And large cell change, wow, it's not letting me, oh, that's weird. So it's not letting me, okay, we're having animation problems. So here's a little bit of liver tissue and a chronically diseased liver, and these are normal appearing hepatocytes over here, and see how these hepatocytes are huge. They're very large. The nuclei are hyperchromatic and sort of odd looking. And so this is called large cell change. It was originally thought to maybe be pre-malignant because the cells look so ugly. They are aneuploid, but they are not considered to be directly pre-malignant. They're a marker of the kind of chronic injury in a liver that also predisposes to cancer. So they're a marker of increased risk of the liver as a whole. They don't usually form nodules of themselves in their own right. They're usually in swaths like this along fibrosepta in advanced stage liver or near portal tracts in an earlier stage liver. There's no architectural atypia to suggest malignancy. And sometimes you get lucky and see features that hint at the fact that these are actually clonal lesions. And I'll get to the clonality issue later on. But so sometimes in a liver that doesn't have much copper in it, you'll have a copper retentive nodule here with a rhodamine stain. Or you have a cirrhotic nodule, lots of iron and a Prussian blue stain, even though the rest of the liver has very little iron around it. These are probably markers of different function of the hepatocytes arising because of throughout the nodule, because it's a clonal expansion and there's epigenetic or genetic modification common to the entire population of cells.
Great. And Neil, and so it was from conversations with Neil about low-grade dysplastic nodules that we came up in LIRADS with the concept of the LIRADS2 distinctive nodule. So I mentioned just a few moments ago that sometimes we see observations and we're not sure whether they're nodules or not. But sometimes we see observations like the ones that are being shown on this current slide with the arrows, and we know that these are nodules. And we know that they're distinctive because they stand out from the rest of the liver, not in terms of color or degree of bulging as would be seen on pathology necessarily, but based on the imaging features. Now, when we have a nodule that is small, less than 20 millimeters, and has no major features of HCC, so there's no arterial phase hyperenhancement, washout, or capsule adherence, there are no ancillary features of malignancy, and there are no LRM features, then we think this is likely benign, and we call it an LR2 distinctive nodule. Now, we don't call it a low-grade dysplastic nodule because we can't make that determination on imaging. That's for Neil to determine if a histology specimen is obtained. So we can't call it a low-grade dysplastic nodule, but we call it an LR2 distinctive nodule. And we believe, but a hint to the audience, this would be a great area for research if anyone is interested. We believe that most LR2 distinctive nodules are in fact low-grade dysplastic nodules, but we have not proven that. If anyone is interested in this as a research topic, I think it would be very interesting. Neil, back to you.
And, you know, similar to us, I can't tell you those 3 nodules I showed you up front, any of the nodules I've shown you. Grossly, I can't tell what they are, whether they're low grade, high grade, or cancer. It requires the histologic evaluation until the gross leaves us in the same position you guys are in radiographically. Okay.
So Neil, there's probably what's happening is there may be a little bit of a lag because you're connected through the internet. So just be patient.
Slower.
Yeah. Well, just be patient. It may take a while for your slide progression to progress. So just be.
I see. Okay. So in terms of high-grade dysplastic nodules, what we're looking for, the first 2 categories are things that start to tell you cancer is starting to happen, either because it looks like cancer or because it's a change we know precedes cancer. So I talked about large cell change as a malignancy associated, but generally, with a few exceptions, not a malignancy, not a pre-malignant lesion. Small cell change is thought to be directly pre-malignant. And one way, it's a hard thing to diagnose even for expert pathologists, but if you see it forming a subnodule like this in a larger area of cirrhotic liver parenchyma, well, that supports the idea that this is actually a pre-malignant change, not a regenerative change. And you see here are normal-sized hepatocytes, and the hepatocytes here are much smaller, and the nuclei appear more crowded, indicating that these have an increased nuclear to cytoplasmic ratio. And I forgot to point out, in the large cell change, despite how weird they are and how big they are, the nuclear to cytoplasmic ratio is normal. These, it's increased, the way you think of it being increased often in cancer. And the nuclei are hyperchromatic and somewhat atypical compared to normal hepatocytes. So this is what small cell change is, and this is felt to be directly premalignant. This does not exist in an periseptal the way large cell change. It can be anywhere in the parenchyma, again, suggesting it's independent of normal processes. These are pseudoglands that we think of most often in HCC, hepatocellular carcinoma. It's an attempt by cells to create a canaliculus, but it can't quite get it right, so you get this dilated structure. It often has bile actually inside it because they're abnormal canaliculi. If you see just a handful like this in a very large nodule, it's hard to call that whole thing cancer. This is where, for a while, we talked about borderline lesions. Is it cancer or not? That term ultimately wasn't used, but this is why we were using it. So this is a malignancy kind of change, and if this was present throughout the entire nodule, you'd be pretty sure you're dealing with an HCC. But if it's just a single focus, it seems that it's just a high-grade dysplastic nodule. And then we have nodule and nodule lesions, or clone-like domains that you can tell grossly, and sometimes you can tell this radiographically. So over here, this is that dark iron retentive nodule in the alcoholic liver I showed you before. And notice when we look at it closely, there's a relatively pale zone looking like a nodule in a nodule. When we put that in the paraffin block, it becomes more distinct that here's the cirrhotic nodule outside, here's the dark iron retentive nodule, that's why it's dark brown to black, and then this subnodule turns out to be iron resistant. And when we look at that histologically, with a Prussian blue stain staining iron blue again, and here's that nodule. Now, it turns out that one of the things we did proliferation studies, and I know the proliferation rates on this particular specimen, this area has a higher proliferation rate than this area does. And in fact, the proliferation rate of the dysplastic nodule itself is lower than the surrounding cirrhotic nodule. And that's something we'll come back to a bit later on. So this nodule and nodule appearance makes it a high-grade dysplastic nodule too. And the fact that this has a higher proliferation rate suggests that another step towards malignancy has been taken, even though cancer isn't clearly developed. And so this begins to introduce the idea of a multi-step pathway to hepatic carcinogenesis.
Yeah, thanks, Neil. And so, you know, the obvious radiologic correlation to what pathologists describe as nodule and nodule is what we in radiology describe also by the same term, nodule and nodule. In LIRADS, this is an ancillary feature favoring malignancy. It's defined in the LIRADS lexicon as the presence of a smaller inner nodule within a larger outer nodule or mass. And just in keeping or in analogous to the pathology construct, what we typically find is that the inner nodule has imaging features suggestive of a more progressed cancer, while the outer nodule tends to have features of either a dysplastic nodule or only early HCC, as listed on this slide. And so here's just an example. Neil was showing an example of iron resistance. I didn't find an example of that immediately for preparation for this lecture, but what I found here is an out-of-phase image, an in-phase image, and then a proton density fat fraction map. Neil, can you just click advance? Okay. And yeah, go ahead. That's fine. So I just wanted to magnify those images, and so in the magnified images, I think you can appreciate, especially on the proton density fat fraction map, that there's a smaller inner nodule within the larger nodule that contains less fat than the outer nodule. And as sort of a side point a little bit here is notice in this particular case that the fat fraction map, which is of course a map that was designed for assessment of chronic liver disease, can sometimes be better than the source images or the clinical images for the characterization of nodules. The nodule and nodule appearance, I think, is much more obvious in this case on the fat fraction map than it is on either the out of phase or the in phase images. So This is another potential area of research, which is the application of fat fraction and R2 star mapping, which was of course created for assessment of chronic liver disease, and the application of those mapping for characterization of individual observations is shown here. So Neil, back to you.
So those are our definitions. The reason these things are important is because they're strongly associated with development of HCC. There were several reports that came from Japan in the, I guess this was the mid-80s. It came from screening programs, usually by ultrasound. They have patients, large populations of patients with chronic liver disease, Hep B, Hep C, alcohol, who are at risk for cancer. And so they thought, if we look for small nodules, maybe we can find cancers early and we can resect them and we could cure them by detecting them early enough. When they started to do that, they found that while some of them were small HCCs, some of them were these other things. And these other things went by various names, but it's what we now call dysplastic nodules. And they saw the range that we just showed you. No atypia, some atypia, a cancer arising inside a lesion, a subnodule, an actual cancer. The first large-scale population study came from Tokushima in Japan, and this was an autopsy series of 315 cirrhotic livers. 14% of them had dysplastic nodules. It was my group at Mount Sinai. I was a liver fellow at the time and just took the 44 sequential liver explants when I was a liver fellow and serially sectioned them at 5-millimeter intervals, because everyone at that point was saying that, oh, this is a Japanese phenomenon. It doesn't happen outside of Japan. And I realized it was because we're not so careful when you get an explanted liver. We would just take a machete and slice, every 3 or 4 centimeters to get an idea of what it looked like inside. When I started slicing them at 5-millimeter intervals, which is now the standard for how these are examined, then there were nodules all over the place, 25% of the livers. Linda Farrell and UCSF followed very quickly with her own series. Yasuni Nakanuma from Japan, his own series. Mike Hitiroglu with me and Swan Thung in New York expanded our series. And this is from Bordeaux, Paulette Bulac-Sage, showing the same thing. And the variations in numbers here probably correlates with variations in how many Hep Cs, how many alcohols, how many PBCs, etc., because each disease has its own particular risk for HCC via dysplastic nodules. And in terms of, which diseases they're associated with, the full range of chronic liver diseases, with the interesting possible exception of Wilson, which doesn't have cancer in advanced stage Wilson disease to anywhere near the same degree you have it elsewhere. And I'm not aware of a case of a dysplastic nodule in Wilson being described. So the association with cancer takes 2 forms. The first is that here you have a low-grade dysplastic nodule that had diffuse steatosis in an explanted liver from a patient with chronic alcohol use. Here's one cancer, and here's another HCC. This HCC also is yellow. It may be a steatohepatitic, or just it's got a lot of steatosis. I don't remember. And it looks like it's got cirrhotomimetic spread. It's spreading through the nodules, leaving the fibrous connective tissue septa in between. So if you didn't have the fat to tell you there was a lesion here, you might not actually see it. And here we have a more typical HCC with an area of necrosis. This is before treatment. So this is just it infarcted itself. And here you've got satellite nodules. So cancers that have livers that have dysplastic nodules in them are at risk for cancer overall. They're markers of malignancy risk for the liver as a whole.
And the radiologic pathologic correlation with that is that there is an entity that was recently described by Utaro Motosugi, the so-called hepatobiliary phase hypointense nodule, without arterial phase hyperenhancement. It's a little bit of a mouthful, but the definition of this term is exactly what it sounds like. It's a nodule that is hypointense in the hepatobiliary phase and lacks arterial phase hyperenhancement and washout, may or may not have transitional phase hypointensity, may or may not have ancillary features like fat. And here is an example of such a nodule, a 10 millimeter nodule, hypointense in the hepatobiliary phase. Notice that it's barely visible in the transitional phase, but really not visible on any of the other phases. So this would be considered an HBP hyponodule without AFI. It's categorized by LIRADS as LIRADS 3. But interestingly, researchers have shown that the presence of such nodules is important, not only because these nodules might become cancer over time, but also, and Neil, if you could just click advance.
I'm trying.
Oh, there it is. Okay. So these nodules, just kind of like what Neil was saying just a moment ago about dysplastic nodules, these nodules are a risk factor for HCC development elsewhere in the liver and for recurrence of HCC elsewhere in the liver after local regional treatment or resection for an established cancer. And this particular patient actually had a 3.3 centimeter HCC in the left lateral section of the liver, as indicated now with the red arrow above. So these nodules are risk factors not only for these nodules becoming HCC, but also for the development of HCC elsewhere in the liver. Okay, Neil, back to you.
So that's the association with dysplastic nodules and HCC somewhere in the liver. But the key thing that caught the Japanese investigators' eye initially was lesions like this. Here's a dysplastic nodule, and here you have subnodules. And when we look at that more closely, same issue. Yeah, I can't use my keyboard to advance. I have to use my mouse for some reason, and it seems to skip it. If we look at this area more closely, we see that here's the background normal sort of appearing liver cells, and then you've got these which are darker, more purple. They have thickened plates, they have abnormal growth, and here's a nodule of HCC with very thick plates that actually is producing its own capsule and then invading through it. And this allows us to start talking a little bit about capsule versus pseudocapsule. Notice that this is a very densely scarred acellular bit of tissue. This is kind of what we talk about when we're talking about capsules around tumors. Compare that to this kind of parenchymal extinction area leading to fibrosis with the inflammation, some edema. If we looked closely, we would find portal tract structures in here from where it's squashed. So this is an area, this is a pseudocapsule created by extinction events and parenchymal collapse, whereas this is the tumor itself producing some elaborated cytokines, chemokines that are stimulating fibrosis, and from what cell, maybe the tumor cell itself, or maybe stellate cells in the surrounding, it's not clear. So this is a true capsule. This is a pseudocapsule. So that's sort of what was recognized. The question is, how does this relate to how cancer actually develops? Right now, we've just got these different categories of lesions that we line up and say, oh, these seem to be a sequence. So the way, still there are clinicians who will talk about cirrhosis being a premalignant lesion. And for years, the idea was you have a normal liver, you have chronic injury of some kind, alcohol, Hep B, Hep C when it was discovered, leading to cirrhosis. And cirrhosis was the premalignant condition because the overwhelming majority in Europe and North America particularly, HCC in the setting of chronic liver disease happened after cirrhosis was developed. And so this led to people thinking about dysplastic nodules in this way. Okay. So no animation. You start out with a pre-existing cirrhotic nodule that's small. Because for whatever reason, it starts to increase its proliferation rate, it becomes large and therefore looks like a large grade dysplastic nodule. Because of that increased proliferation, it's become susceptible to genetic mutational events that lends to the emergence of atypia within the nodule, giving you a high-grade dysplastic nodule, which is still further highly proliferative, and so more risk for mutational events, leading eventually to the cancer arising inside the nodule that then, if left alone, grows to demolish the pre-existing nodule, and you have a progressed HCC. So this is how people explain these things for about a decade. But this left out some key things. The first key thing is that HCCs exist in chronic liver disease when there's no cirrhosis. So how do you explain a cirrhotic nodule becoming a rapidly proliferative larger nodule if there's no nodule in the first place? And in particular, we found this case. It was a case report we published in Hepatology back in 1993. Yeah. So this was a liver that probably was hepatitis C. I think we didn't know at the time. And the entire liver had this single nodule in the middle of it. And when we looked at that single nodule, we thought, oh, that looks like an HCC. But when we looked at it closely, we found out that it's a whole bunch of HCCs, all existing simultaneously. And I think we counted 23 different forms of HCC in the serial sections of this lesion. How is it that all of these HCCs, which look different from each other, were clustered in this area that was like 1.5 centimeters across, even though there was nothing anywhere else in the entire liver? And it wasn't cirrhotomimetic spread because each of these cancers was different from the neighboring cancers. So this was a puzzle. And this led me to think there had to be a different way to explain things. So this actually started as an H&E image, but I lost that Kodachrome. Let's say you have a normal liver that has portal tract, there's the bile duct, artery, vein, here's the central vein, the liver cells in between, and this liver becomes diseased, let's say with chronic B or chronic C or alcohol. And that's going to lead to hepatocyte injury, which is going to increase hepatocyte turnover generally. It's going to lead to epigenetic changes, and because there's increased turnover, there is an increased proliferation rate and increased risk for mutational changes too. So either genetically or epigenetically, an hepatocyte will transform into something a little bit different and become neoplastic. Now, if this cell spreads, not because it's rapidly growing and therefore pushing things out of the way a cancer would, but let's say it's slowly proliferative, then it would spread gradually surrounding structures rather than pushing them out of the way. So, and we know that these lesions can take 10 to 20 years to develop, so they've got to be very slow proliferative lesions. The question is, if it's slowly proliferative, why is it actually able to expand? Because the rest of the liver is diseased with high cell turnover, and if these cells would be resistant to apoptosis, then they'd have a survival advantage and very slowly replace the liver parenchyma. So we've got two predictions we could make on this model. And then let's say the rest of the liver, as it scars around, becomes cirrhotic. If this is resistant to scarring, it will look like a large cirrhotic nodule, but in fact, it's an island of preserved hepatic parenchyma made up of neoplastic hepatocytes. It's not a cirrhotic, it's not simply a large, highly proliferative cirrhotic nodule. So we made three predictions. DNs are low proliferative lesions, they're resistant to apoptosis, and they have diminished stellate cell activation. And in fact, all of those predictions were met when we studied the nodules for them. And so here we can schematicize it a little bit like this. You have a spreading monoclonal proliferation that if there's diminished stellate cell activation, the cells responsible for deposition of collagen, then as cirrhosis develops, you wind up with a clonal dysplastic nodule. And then a nodule, and because this has already had epigenetic and genetic changes that put it on the path to cancer, it's more ready to accumulate more, and you wind up having HCC development. This depends on this idea that these are clonal lesions, starting from that one cell that I showed you. And that came from work in 1994. This was the first clonality study of dysplastic nodules. and it relied on, they were hepatitis C patients, and it relied on determining exon activation nodule by nodule. There are more sophisticated ways of doing this now, but they've all shown basically the same sort of thing. In hepatitis C, it turned out that 40% of the nodules in a hepatitis C cirrhosis in this study were not hyperplastic and polyclonal. They were neoplastic and monoclonal, 40% of them. So that meant they were clonal expansions of neoplastic hepatocytes involving 40% of the liver parenchyma. Early stage clonal expansion. Then when they looked at which X had been inactivated in these nodules, they weren't randomly distributed, which is what people would have expected at the time. It turned out that there were patches of nodules that either inactivated one X chromosome or the other X chromosome. This clustering meant then that the malignant expansion had to exist, the neoplastic expansion had to exist prior to the scarring, as this model has suggested. And because it's already pre-malignant, it's already gone through some of the genetic and epigenetic changes, then you're likely to have increased risk of multiple cancers arising simultaneously in the same area. But you don't have a pre-existing dysplastic nodule, because in this case, like this lesion, oops, go ahead, take it from there, and then we'll follow up.
No, it's back to you, Neil. Okay, well.
Do you want me to do that, or?
No, that's fine. Okay, so stay here. Okay, perfect. So when I read Neil's papers from the when in the 2010s, I read Neil's papers from the 1990s, and then discussed it further with him. We were in the LIRADS committee very struck by the fact that what was known in pathology was that regenerative nodules may look normal on gross pathology. They may look normal on histology, and it's only when these more advanced clonal proliferation studies or clonal studies are done that they realize that many of these regenerative nodules are actually neoplastic. They're already clonal expansions. And so while we can take an observation that is distinctive from the background liver and assign it a LIRADS category, so now go forward. So you may be tempted to then say all of these background nodules that all look the same, therefore must be definitely benign, and you might be tempted to say that all these nodules are therefore LIRADS 1, definitely benign, and now advance forward. Oops. But you cannot do that. So the reason that we do not assign LIRADS 1 to the background nodules is that even though all the background nodules look exactly like every other background nodule, we now know from the world of pathology that many of these background nodules already harbor neoplastic change, and therefore they cannot be considered 100% definitely benign. So what do we do with these background nodules? We observe them, we note them, we use them to convince ourselves that they help increase our confidence that we're looking at a cirrhotic liver, in which case LIRADS applies, but we do not assign LIRADS categories to these background nodules because there's no way of knowing with 100% certainty that they are truly benign from a biological and molecular standpoint. And Neil, back to you.
Yeah, I would just modify your language slightly. I would say you can't tell that they're benign. We know they're benign. We can't tell whether they're neoplastic or hyperplastic. Are they neoplasia or are they just regular old hepatocytes? That would be the distinction, you know, and it's a subtle thing, but I
follow you. I follow you. I follow what you're saying.
Okay, cool. So if you have normal or increased stellate cell activation, then the nodule, then that expanding, spreading monoclonal neoplastic proliferation does subdivide. You don't get a dysplastic nodule, you get adjacent clonal cirrhotic nodules, and in the same way, these become capable of becoming malignancy. And they may have indistinct borders compared to the sort of thing that we're seeing over here. So this is the premalignant lesion implied by dysplastic nodules, but we also see this pathway too. And if you see cancer blooming in a cirrhotic liver without the pre-existing lesion, it's probably going through this pathway. And the small cell change I showed you before that we see in cirrhotic nodules without any dysplastic nodules, without any malignancy, is probably arising in this as it becomes this. And then, then we get to, I think, 2009, and the Japanese and non-Japanese investigators finally all got in a room together. There were about 20 of us, and we formalized a classification that then extended to include early HCCs. And this coming out of predominantly the Japanese literature, early HCC, vaguely nodular type. This looks like a nodule, but histologically, and see it's sort of yellow-orange, so here's the fat of the cancer. But are these malignant hepatocytes? I can't tell by looking at them. And here's the non-malignant tissue over here. Where's the boundary? Are these cells, or are these cells, these cells? I can't tell. And so you have this vaguely nodular appearance because this whole area has been neoplastically transformed, and the cancer is arising here sort of, I wish you could see my hand gestures, it's sort of flowering here. But as this becomes more rapidly proliferative, it starts to push things out of the way, and then you develop a pseudocapsule because of compression of the rapidly growing tumor, compressing the surrounding cirrhotic parenchyma, and these stars represent areas where you actually have portal tract remnants because these fibrosepta are collapsing as they're compressed, and these hepatocytes, because of the compression, are atrophying away, and that's where you get your pseudocapsule from, around a progressed or distinctly nodular type of cancer. So this is where we come to the international consensus of 2009. Claude, I think, take it from here.
Sure. So this is a schematic representation of the various types of nodules that Neil has been speaking about so far. So we see low-grade dysplastic nodule, high-grade dysplastic nodule, well-differentiated HCC, and moderately differentiated HCC with the clinical pathologic categories of benign, in quotation marks, pre-malignant, early HCC, and progressed HCC. On gross pathology, the early HCCs are characteristically vaguely nodular, and the progressed HCCs are characteristically distinctly nodular. And as Neil pointed out, one of the key elements in the distinction is the presence of stromal invasion. Notice that stromal invasion can sometimes be seen histologically for the HCCs, but is not seen for either flavor of dysplastic nodule. So then we might wonder, okay, well, what is it that we see as a radiologist? Well, one thing that has not been addressed is, can you go back? Yeah. One thing that has not been addressed is, can we tell the difference radiologically between vaguely nodular and distinctly nodular? I would say that based on my own anecdotal experience, we often cannot. I would say that most nodules look distinctly nodular, so that's something to be aware of. Stromal invasion is something we cannot assess.
Sorry, I'm trying to anticipate.
No, that's okay. So let's go on to the next one. Now notice during carcinogenesis what's happening to the portal triads, which are the blue circle next to the red circle. And notice what's happening to the development of unpaired tumoral arteries, which are the isolated red circles. So notice that the portal triads diminish over time while the unpaired arteries increase over time, so that by the time we get to progressed HCC, we essentially have only unpaired arteries and no portal triads. And so, yeah, so based on this, if you sort of sum for yourself the sort of net inflow to the liver via both unpaired arteries and normal triadal arteries, you can see that in general, the arterial flow will decrease during carcinogenesis and then start increasing when we get to progressed HCC. The portal flow, on the other hand, should gradually diminish over time. And these are some of the mechanisms that help explain arterial phase hyperenhancement and washout. Washout, I should point out, is complicated. and is worthy of its own discussion maybe some other time. So let's now move on to the next one. And I want to just show schematically what happens to iron accumulation and fat accumulation over time. So now if you could advance forward one click.
I'm trying. Oh. Sorry.
No, that's okay. So what I'm trying to illustrate here is summarize what Neil has been mentioning in the last several slides, which is that iron accumulation is something that can develop in these nodules. It typically is most frequent in low-grade dysplastic nodules, and notice that it becomes less frequent with some of the other nodules. So when we see a nodule that's chock full of iron on MRI, we think that it's likely a low-grade dysplastic nodule, and that's why iron accumulation is an ancillary feature favoring benignity as opposed to favoring malignancy. On the other hand,
if I can jump into that,
yeah.
The reason for that is that for iron to accumulate in a hepatocyte like this, it has to be a low proliferative hepatocyte, because every time an hepatocyte with iron in it divides, it's going to subdivide its iron stores. So because these are low proliferative lesions, they can accumulate the iron. These become higher proliferative lesions, though often still not as proliferative as surrounding cirrhotic nodules, and the iron rapidly diminishes because the cells are dividing and subdividing their iron stores. That's why that happens.
Interesting. So even though you guys call it iron resistance, maybe it's not so much as an iron resistance as more of an iron dilution.
Yeah, yeah, yep.
Now with fat, the story is a little bit different, and if time permits, Neil may talk a little bit about the pathophysiologic mechanism for this, but fat is something that is not always, but can be frequently observed in well-differentiated HCC. In more progressed HCCs, it's less common to have fat, except that there are some variants of HCC that do accumulate fat. One of them is the steatohepatitic HCC. So some HCCs do accumulate fat, and that's what this sort of little dotted line curving upwards is supposed to represent. But as a general rule, the presence of fat within an HCC suggests, or within a nodule suggests that it's either that it may be an early HCC or high-grade dysplastic nodule. So the presence of fat is an ancillary feature that generally favors malignancy. And back, now it might be tempting to think that there's a one-to-one correspondence between these various nodules and the LIRADS categories as illustrated on this slide, but such a temptation would lead you the wrong path. And so click forward one. Instead, the relationship between the histologic nodules and LIRADS is a little bit more complicated. So let's...
Oh, sorry.
No, that's okay. Okay, so if we look at HCCs and ask ourselves what percentage of HCCs belong to the various LIRADS categories, it turns out that about 0 to 8% of HCCs will be categorized LIRADS 2, at least according to the published literature. 2 to 23% of HCCs will be categorized LIRADS 3, 12 to 38% LIRADS 4. The bulk of them, 52 to 73% LIRADS 5, and a non-substantial, or I should say a relatively meaningful minority, 11 to 25% will be categorized LRM. And this sort of funny shape that you see in front of you is sort of trying to schematically represent that distribution of categories for HCC. So now, Neil, if you could advance one click. And if you might wonder what it might look like for low-grade dysplastic nodules and high-grade dysplastic nodules. And this is our current model. It's a model because we don't yet have enough empirical data. So this would be another area of research for those of you who are interested. So our model is that the majority of low-grade dysplastic nodules, if assigned the LIRADS category, would be assigned the category of LR2, with smaller numbers being assigned 3 and 4. High-grade dysplastic nodules, we hypothesize that the majority would be assigned to LIRADS 3, but smaller amounts be categorized either LIRADS 2 or one of the higher categories. And you can go forward. Now, what if we look at it from a different perspective? What if we ask the question, instead of going from pathology to radiology, what if we ask the question, let's go from radiology to pathology? So in the published literature, 13% of LIRADS2 are HCC, and then click forward, and 38% of LIRADS3 are HCC, and click forward. 74% of LIRADS4 are HCC, 94% of LIRADS5, and 36% of LIRADS-M are HCC. So the key message here is there's not a simple one-to-one correspondence between these histologic nodules and the LIRADS categories. The exact relationship is complicated. Data is emerging. I encourage those of you in the call who are interested to participate in research to try to unearth some of these questions. And Neil, back to you.
So just to summarize the features that we've sort of described, we can have things that are distinctive within the grossly distinct nodules. In low-grade dysplastic nodules, you have the potential for increased iron, diffuse or zonal fatty change that you don't see elsewhere in the liver, serous change, sort of fibrosis within the lesion. I'll show you an example of that, and large cell change. Angiogenesis, these unpaired arteries, unpaired because they're arteries not accompanied by a bile duct, and so therefore they must be angiogenesis. We showed in a lot of studies, as did others, this is one of the more well-studied parts of dysplastic nodules, that you have increasing angiogenesis, as Claude showed, as you get progression from low-grade to high-grade lesions. High-grade dysplastic nodules, the sort of things that I showed you already. And then this final thing about stromal invasion. There's an interesting history to this, but we don't really have time for it. In a nutshell, like at that case I showed you before, here's a portal tract, here's a cancer, here's not cancer. What are these cells here? Are they cancer or are they not cancer? Or is it, if it's not cancer, is it just a small cirrhotic nodule bounded by fibrous tissue? We realized, and this was a tricky point for the non-Japanese pathologists to recognize until we all got in a room together. To make it easier for us, we realized that if you stain for small cirrhotic nodules within fibrous septa for biliary keratins, you can see the stem cell response, ductular reactions around those nodules of hepatocytes. So we went back and looked at things like this, and sure enough, there's no ductular reaction. Therefore, this is not a small trapped nodule of hepatocytes. This is an HCC invading into the stroma of a nearby portal tract. So this is stromal invasion. And this is the earliest feature of invasive HCC. We don't see it too often in pathology specimens, but we'll show you one. And then, do you want to talk about OATP expression?
Yeah, very, very briefly. In radiology, we often use a contrast agent, gadoxetate. And gadoxetate is an agent that gets taken up by hepatocytes via OATP transporters. And what investigators mainly out of Japan and Korea have observed is that OATP expression tends to decrease, as shown at the bottom of this slide, during the progression of the nodules from more to less differentiated. And so this is shown schematically on the next slide. Right here, where OATP expression tends to decrease from low-grade dysplastic nodule to moderately differentiated HCC. But then if you click forward one click, that there are about 5 or 10% of moderately differentiated HCCs do have OATP expression. But it's important to understand that the current thinking is that this represents a new mutational or epigenetic change, and that's what's being illustrated here by the dotted curved line, that these are not HCCs that necessarily had OATP expression all the way along their development, but rather that at some point after they became HCCs, they developed a new mutation or a new epigenetic change that led to OATP overexpression. And here's just an example of a woman who has 2 HCCs in the same liver. In the top row, we see that this HCC has OATP hyperexpression and is bright compared to background liver. And on the bottom, we see a nodule that is dark because and there's a typographical error for which I apologize. That one is OATP negative.
Negative. Do we have time?
Khaled, should we pause now for questions rather than go through the cases?
I think no, I think if you guys have time, you should just move on, because people are enjoying it, and even if someone has anything to do, they can come back and watch the recording. So I would, I mean, unless you guys have any conflict or anything, but we're all enjoying it. I'm receiving a lot of good feedback already about the lecture. So people have been sticking to the lecture despite of the time extension, and you know, I'm just very appreciative of that. So if you would like to, if you have time, it's your call, you and Neil call. If you guys have time,
I can keep going. Are you okay?
Yeah, let's go for it.
Yeah.
Yep.
Okay, go ahead.
Okay.
If anyone has anything to do right now, you guys can go, and this will be recorded. This is already recorded, so go ahead, Neil and Claude.
Okay, well, thank you. So now we're going to switch gears just a little bit. I'm going to go through a few cases, but now we're going to kind of show the gross, do the radiology, and then we'll turn it over to Neil to discuss the histology. And I think this exercise will give us some insights into the biology of these tumors and into why the LIRADS imaging features are the way they are. So case number 1, we see in segment 3 a 1.5 centimeter HCC. On the gross pathology, let's see if I can get this language correct, I would say that this is a distinctive nodule. I would not know, based on this gross pathology, that this is a cancer. Neil will show that to us later. Now, the imaging is shown on the right. We can see that pre-contrast, this lesion is T1 bright. One reason it might be T1 bright is because it may contain copper. That is a hypothesis for why some lesions are T1 bright. There's probably other mechanisms, but that might be one mechanism. In the early arterial phase, this nodule is heterogeneous. Notice that it was homogeneous pre-contrast, homogeneously bright, and now it's heterogeneously sort of iso-intense to background liver. The fact that it went from homogeneous to heterogeneous means that it's clearly enhancing. Portions of it must be enhancing more than other portions of it. So this is not a dead tumor or dead nodule. There's blood flow going into this thing. But the lesion is not brighter than the background liver in the early arterial phase, and it's not brighter than background liver in the late arterial phase. So we do not call this arterial phase hyperenhancement. On the 3-minute delay, the lesion is darker than composite background liver. And if we look, the lesion is surrounded by a rim of relatively conspicuous enhancement. So there's enhancement around this lesion, which we call a capsule appearance. We call it a capsule appearance because in the year 2020, we are not sure if this is going to be a true tumor capsule or if this is going to be a pseudocapsule. Neil is going to tell us that piece of information in just a moment. So we go to the LIRADS table. The lesion is less than 20 millimeters. There's no arterial phase hyperenhancement. There is an enhancing capsule appearance. There is non-peripheral washout, and this therefore is a LIRADS for probably HCC. And now Neil will tell us what it really is.
So here's histology. We were doing this, again, this is thanks to Krishna and Miles, who managed to pull cases. I found cirrhotic livers that we had grossed in the last year that had nodules. They went and found which of those had images and then which were good cases. So we've been sort of rushing to put this together. So here's the larger nodule. Here's the surrounding cirrhosis. And again, you look at this tissue here. Is this different than this? It doesn't look so at this level. Are there portal tracts in here? I can't tell. Got to look closer. I've got this funny box again. So if we look at this area, sorry, I left it out of the lower power. You see that this is the pseudocapsule, which looks basically pretty much the same as the cirrhotic nodules around it. This looks like a portal tract remnant. There's an artery, there's the portal vein. If there's no bile duct here, it's probably because the arterial flow has been squeezed and it's atrophied away. and it's inflamed. And this is the HCC over here, which we can look at a little bit more closely. You see here a portal vein probably being squashed in this area of parenchymal extinction. There's more of that pseudocapsule, and if we look at this more closely, we see 3 different variants of HCC within the larger nodule. We have a well-differentiated HCC. These just look like normal hepatocytes, but the growth pattern and the NC ratio, the growth pattern being thickened plates, and the high NC ratio compared to actually normal hepatocytes tells you it's a well-differentiated HCC. Here's a clear cell variant of HCC, and here's a steatotic variant of HCC. And so this is probably in part where the variegation comes from what you were seeing radiographically. I also noticed that there's inspissated bile here, and copper is excreted in bile, so I wonder whether the possibility of increased copper is coming because the HCC is not excreting bile. It's making it, but it's not excreting it. So that's
okay.
that.
One question for you, actually, can you go back for just a second? Do you believe, or do the fact that there's 3 different types of HCC also close together, are these different clonal expansions of cells, or how do you explain this?
It's probably a mix of things. Well, number one, the entire thing is clonal, but then you certainly have subclones arising. We know that that's how many cancers progress. They develop subclones that diverge from each other. But steatosis itself can happen in any hepatocyte, benign or malignant, in part modulated by the ratio, it's believed, of arterial flow to portal vein flow. And there's a window in which arterialization starts to predominate. You sort of hinted at that in your earlier slide, that hepatocytes, benign or malignant, start storing fat, storing lipid. So is this a different clone than this, or is it simply arterialized? Is there a arterial to portal vein ratio here, and this is more arterialized, so it's lost it? Or it hasn't reached that point, so it hasn't started accumulating it. I don't know. But my guess is that this is genetically or epigenetically different than this. And again, this notion of genetics versus epigenetics, some of these things are about mutational events. But a lot of what goes on in HCC, and in fact, malignant transformation itself, may very well be driven by epigenetics and therefore be reversible in some fashion. And this is a very hot area, very quickly evolving as the technology allows us to look at these questions. HCC is very funny in a lot of ways and not like other tumors, and this may be one of them.
Interesting. Thank you, Neil. Okay, so this is case number 2, and I realize now that probably we shouldn't have given away the answer, so next time we will take away the answer. So you know the answer. You know this is going to be a 1.3 centimeter HCC arising in a high-grade dysplastic nodule. I wish when we were looking at the MRIs we had that knowledge in advance, but of course we don't. So on the radiology, I see a small observation. It's T1 bright, just like the previous one. And then notice in the early arterial phase and late arterial phase that, again, we see a bright spot corresponding to the observation on the pre-contrast image. And the very astute observer might notice that the bright spot looks a little bit bigger in the early and late arterial phase compared to pre-contrast. And if you were confident that it was bigger and you were confident that there was no motion artifact or other technical artifact, you might say, okay, that's arterial phase hyperenhancement. I myself am not quite so confident in this case. Is that really arterial phase hyperenhancement? When we look at the subtractions that are immediately below the source images, it's not convincing to me. And so the rule in radiology is if you're not sure that an imaging feature is present, don't call it. So I am not sure whether there's arterial phase hyperenhancement. And so me personally, I would say there is not. But, you know, this is an area of research. And if there are people who are listening in and watching this case disagree with me, that's okay. Maybe you would call this arterial phase hyperenhancement. I would not. Now, on the 3-minute delayed, the observation is clearly darker than background liver, so there is a washout appearance. We do not see a distinctive rim of enhancement around this lesion, so this is not a capsule appearance. And notice that the lesion is invisible on T2. So when we go to the LIRADS table, I would say no arterial phase hyperenhancement. I would say there's washout, but nothing else, and so I'd call it an LR3. If, on the other hand, you felt that there was let's say you thought there was arterial phase hyperenhancement, you were convinced of it, then you would actually end up in that diagonal cell, which I did not highlight for you, and this would end up being a LIRADS 5. So the distinction between arterial phase hyperenhancement and no arterial hyperenhancement is quite important. It's the difference between definite HCC and intermediate probability. I would end up calling this a LIRADS 3. So Neil, tell us why this is an HCC arising in a high-grade dysplastic nodule.
Okay, so here's the low power view, the background cirrhosis. Here's the lesion. And already over here, you see part of the lesion streaming into another part. That's a bad sign. Oops. Here's that area. And here you've got what looks like different stuff. And this is different, and this is different, and this is different, and this is different. And this streaming area over here. When we look at this streaming area carefully, what do we see? Here are bile ducts. And here's stroma. And here's HCC with stromal invasion. And it's invading through the stroma and out the other side into the surrounding parenchyma. So that's invasive cancer. But histologically, these themselves are atypical enough. The trabeculae are thick. The pleomorphism is suggestive of HCC, but this confirms it. And you know it's stromal invasion because there's a remnant of the portal tract. When we look at other areas, here we've got a steatohepatic focus where you've got actual hepatocyte ballooning and Mallory-Dank bodies inside, as well as steatosis. So this is that steatohepatic variant that looks like alcoholic liver disease, except it's a cancer. Then you have a well-differentiated HCC, clearly hepatocytes, monomorphic, not very pleomorphic, but high NC ratio, thickened plates, abnormal growth structures. But then you have a not atypical background, and this is within the nodule. So this is the pre-existing dysplastic nodule giving rise to a cancer. So this is cancer arising in a background of a dysplastic nodule. There's a little pseudogland there. So if the whole nodule looked like this, it would be a high-grade dysplastic nodule. If the whole thing looked like this, well, this is HCC arising in the dysplastic nodule. And this bit over here we already showed is invading.
Neil, does steatohepatic HCC occur only in the setting of alcohol and NASH, or is it seen in virus?
No. It can occur in any setting. I think it seems to me, I'd have to actually look this up, but it seems to me they're more typical when the whole liver is being exposed to the same thing and the hepatocytes are, so either non-alcoholic or alcoholic fatty liver disease, but I have definitely seen them in the absence of that. So it's both the environment and the nature of the genetic and epigenetic alterations in the cell that are leading to these changes.
Great. Okay, and so here's a 1.2 centimeter, and we know what it's going to end up being. It's an HCC. Cases 3 and 4 are from the same patient. Notice on the gross specimen that there's just tremendous hypertrophy of the central portion of the liver, including the caudate. And there's a peripheral sort of atrophy of the liver, at least that's how we would describe it from an imaging perspective. On the imaging itself, we can see that there's all these dilated bile ducts. On the gross specimen, the dilated bile ducts don't seem so obvious to me, but perhaps they seem obvious to Neil. Now, this liver has 2 nodules, and case number 3, we're focusing on the nodule that's labeled with the orange arrow. This lesion does not enhance in the arterial phase. At least I'm not confident that it's enhancing, so I'm going to say no arterial phase hyperenhancement. It is washing out on the 3-minute delayed. Notice that from the early arterial phase to the 3-minute image, the nodule went from essentially iso-intense to liver to clearly darker. And if you look at the 3-minute delayed, there is a rim of enhancement, and I would call that a capsule appearance. So there's a capsule, there's washout, there's no AFI, it's less than 20 millimeters, and this is LIRADS for probable HCC on the basis of imaging.
Here's the large nodule, and here's the surrounding liver parenchyma. It's primary sclerosing cholangitis, and so notice that instead of having discrete round or oval nodules, you have these jigsaw puzzle-shaped pieces. So part of the conversation earlier about distinguishing different cirrhosis, different forms of cirrhosis, the pathology community, some of us are trying to push towards the idea of, number one, getting rid of the word cirrhosis and just saying advanced stage PSC, which has its own appearance, advanced stage Hep C, which has its own appearance. And if we want to use the word cirrhosis, we talk about cirrhoses, plural, and this is PSC cirrhosis. And so here we've got the tumor, the lesion, and here's the background cirrhosis. And if we look closely, again, we see this isn't a true capsule, it's a pseudo-capsule. Biliary, any advanced stage biliary tract disease, PSC, PBC, chronic obstruction, you have not only these weird shaped jigsaw puzzle nodules, but you have this peripheral halo, which is distinctive for chronic biliary tract disease. You don't have that over here. And if we look closely at the interface, we see tons of pseudoglands all over the place and clear cell change. And so this is a well-differentiated HCC arising in a background of primary sclerosing cholangitis.
Same patient, a little bit posterior and inferior to that first lesion, but also in segment 7. And we know the answer, it's going to be a 9-millimeter low-grade dysplastic nodule. Notice how similar it looks on imaging to the prior lesion. The only difference here is it's a little bit smaller. It's and there's no quote-unquote rim of enhancement on the delayed images. So this one, I would say, I would call on imaging a LIRADS 3 because of the presence of washout, no AFI, and no capsule in this case, so LIRADS 3.
And this is really interesting to me. It's kind of an unusual lesion because, you know, is there a lesion here? I can tell you when you look at the slide, I tried to take a picture of it. It looks like a lesion like it looks on the gross. But you look histologically, and it's this. And the difference between this and this seems to be there's simply way more sclerosis. It seems like this is a more advanced stage of cirrhosis than this is, if one can make such distinctions, which technically one can't. Is this a Sirrhosis variant of dysplastic nodule? Maybe. But when we look at it closely, we see that the hepatocytes show no small cell change, no large cell change. The periseptal hepatocytes have the edema of the rest of the liver that I described before. We do have portal tracts inside, some of which there's an artery, but there's no bile duct to accompany it. There's another artery, no bile duct. So the features you'd expect of PSC, because low-grade dysplastic nodules, don't forget, have portal tracts inside them. This would be a low-grade dysplastic nodule, I would say, which was susceptible to scarring and therefore scarred down inside, though it seems at a different rate than the surrounding liver. Maybe the hepatocyte, maybe the stellate cells in here were actually more ready to lay down scar tissue. I don't know.
But Neil, just to clarify, if you don't mind,
Yep.
It sounds like the only reason that you're calling this a low-grade dysplastic nodule as opposed to calling it nothing is that on the gross pathology, it was distinctive from the background liver. And so it's in the dysplastic nodule or worse now bucket, but then histologically, it looks just like background liver, and that's why you're calling it a low-grade dysplastic nodule?
Right. And so that gets into an area of controversy that actually my group here has some new data on. We're trying to pull it together. Can you tell a low-grade dysplastic nodule from a large regenerative nodule? No. The only way, not histologically, the only way you could is by doing clonality studies. If it's clonal, it's a low-grade dysplastic nodule. If it's not, it's it's an area of regenerative hyperplasia. So we would need to do clonality studies on this. Some new data that we have looking at, we've done some pretty high detailed molecular analysis. Alejandro Vargas and George Jur, a resident and attending here in the molecular pathology lab, have looked at a whole bunch of nodules. And one of the things that fell out is that low-grade dysplastic nodules are clearly not normal like cirrhotic nodules in terms of their genetic profile, but they're not like HCC either. And it may be that lesions like this are truly neoplastic, but not premalignant. And that's a much more complicated story, and we're just starting to sort it out. So the short answer is no, histologically, we can't always be sure that we've got a low-grade dysplastic nodule as opposed to a large regenerative nodule.
Right, and just for the benefit of the audience, so earlier when you were saying that you're looking for clonal features, the idea here is that if you see something histologically that makes you think that it's a clonal nodule, then that reassures you, or that's evidence that it's in fact a dysplastic nodule, because in fact you cannot do clonality studies on every single nodule that comes your way on a clinical basis. Is that right?
With infinite resources we could, but we don't have those. Yes.
Right. Exactly. Exactly. Okay. So tell us a little bit about this lymphangiogenesis.
Oh, forgot about that. So often in advanced stage liver disease, you see these large vessels, and we know they're lymphatics, not veins, because when you stain the endothelial cells that line them, they stain for markers of lymphatic endothelium like D240 or Live1, and not CD34, a typical capillary or vascular endothelium. And it's just an association that in patients who have clinical portal hypertension, when you get the liver resection, either because of an explant or a tumor resection, they often have this lymphangiogenesis. The lymphatic drainage of the liver is an obscure little area that no one's really exactly sure of the architecture of things, but what goes back 100 years is the idea that the space of DISA, the space between the sinusoidal endothelium and the hepatocytes, enters the portal tract into something called the space of Moll. Franklin Moll discovered it back in 1904 in Johns Hopkins, but no one ever sees a space of Moll, and that's a pre-lymphatic space for a variety of reasons. What you see here is big honking lymphangioles in the middle of where this subtle shift happens. So how these arrive here, how they develop, total mystery. This links up with my more recent work on the interstitial spaces in fiber connective tissue, and realizing that the portal tract stroma has interstitium in it, and that is the space of Moll in the liver. He was looking at what we're calling interstitium 100 years ago. So this is a big edge, leading edge of research that needs to be done. For pathologists who are listening in on this, there's some projects for you.
Yeah, and I would say for the radiologists as well. I think, you know, we can discuss this further offline, but I think there might be some interest in pursuing the radiologic detection and characterization of some of these lymphatics. We, of course, would not be able to see the lymphatics at the microscopic level, but what I think we probably can see, at least in some cases, is the delayed enhancement into the lymphatic channels in aggregate by contrast material that eventually makes its way into the interstitial space. So not that we would see individual lymphatics, but I believe we can see the aggregate of multiple lymphatic channels. But that is a topic for perhaps another day.
And there we are.